Good afternoon, everyone. My name is Tyler Logan, and on behalf of the Wayne State University School of Social Work, Center for Behavioral Health and Justice, I would like to thank you all for joining us during today's Community of Practice webinar, titled Addressing Behavioral Health in COVID-19 in Jail Settings and Beyond. Next slide, please, Stacy. Again, welcome. This is our fourth event within the Mitigating COVID-19 in County Jail series of webinars. Whether you are joining us for the first time or are a returning participant, again, welcome and thank you so much for taking time out of your day to join us today. So as we wrap up Women's History Month, we have phenomenal women for today's presenters and panel discussion, and I'm very excited to share the platform with them today. For the agenda, we will of course tackle Zoom housekeeping per usual, and then we'll jump into the sequential intercept model, a brief overview provided by Nancy Hambrick. We'll then shift over to Dr. Carmen Mcintyre for risk factors for people who are incarcerated with behavioral health needs during the COVID pandemic. And then we'll also hear from Dr. Melissa Zielinski around incarceration, isolation, and COVID-19, compounding risk and possible mitigation strategies. Of course, there will be an opportunity for you all to ask questions. So again, the chat box is disabled, but the Q&A chat box feature is available so that when we get to the panel discussion portion, you are able to ask those questions based off of the content presented today. And then, of course, we will wrap up with conclusions and next steps. For Zoom housekeeping, the slides will be made available after today's webinar. This session will be recorded and again, made publicly available. And then lastly, just to reiterate, the Q&A chat box feature is open and you can submit your questions there throughout the presentation. Next slide, please. And now I will hand it over to my coworker, Nancy Hambrick, for her presentation titled Sequential Intercept Model, a brief overview. Thank you so much.
Hi, everyone. Thanks for being here today. It's nice to see you. And I am a project coordinator with the Center for Behavioral Health and Justice. And what that means is that I have been able to work with jails throughout Michigan as they face challenges with their behavioral health population. So I've worked with rural jails, with large metropolitan jails, and everywhere in between. And I'm really excited to be here today. Next slide. Some of you may be familiar with this, and it might be new for others. So essentially, the sequential intercept model was developed as a framework to look at how people with behavioral health needs come into contact with the criminal justice system. And before I go any further, something that I've learned in working with jails and then community providers and county governments is that we all use different language to talk about the same things. So here, when I use the term behavioral health, it encompasses a variety of things. So it will encompass mental illness, such as depression and anxiety and schizophrenia, as well as substance use disorders. So opioid use, alcoholism, those issues, as well as cover people with intellectual and developmental disabilities, such as people on the autism spectrum. So just wanted to put that out there, that is how we're using the term behavioral health today. And this sequential intercept model is designed to look at ways to intercept people with behavioral health needs as they come into contact with the criminal justice system. So interestingly, when this was created, it was only intercepts 1 through 5. So intercept 1 is law enforcement. Intercept 2 is initial detention in court hearings. Intercept 3, which I know most of you all are most familiar with, are jails and courts. Intercept 4 is focused on reentry, and then Intercept 5 is focused on community corrections. And luckily now we do have an Intercept 0, which is really focused on identifying people and treating them in the community with the goal of keeping them from ever interacting with the criminal justice system. Next slide, please. So I won't spend too much time here, but what I really want to point out is that there are a lot of efforts to divert people with behavioral health needs across this entire sequential intercept model. I'm sure as you all have watched the news lately, there's a huge focus on Intercept 0, which is connecting people with behavioral health needs to treatment in the community. There's a lot of focus on police and mental health partnerships. As far as this relates to jails in Intercept 3, diversion involves identifying people with behavioral health needs as soon as they book into the jail, and then providing them with treatment through jail medical while they're in there, and then connecting them with treatment on their way out. Next slide, please. So as a research organization and a data geek myself, what we always focus at is what does the data teach us about what works at each of these intercepts? And again, recognizing the jail folks here today, the thing that I want to talk to you about that we've really noticed in Intercept 3, in addition to identifying people, is the value of training in de-escalation techniques. So one study that we were involved in a large metropolitan county looked at how many times the cell extraction team was used for to handle a situation. And we looked at a period of time before this training and looked at how often it was used. And then officers went through an 8-hour training on de-escalation techniques. And then we studied the next year, how often was the cell extraction team used? And what we found is there was a 50% decrease in the use of that team. And how that translates, correction officer safety, inmate safety, all of that was improved based on a pretty quick de-escalation training. And interestingly enough, too, I was involved in some of the correction officer interviews around this. And what we kept hearing was that the de-escalation training, while it was geared towards their use in the jail, I had an officer tell me that he loved using it with his teenage daughter and that he found many other ways to use this de-escalation training technique elsewhere. So that's just kind of something that we've really been interested in seeing jails use. Next slide, please. So there are a lot of best practices across each of these intercepts that I won't go into too deep because I understand again that we're specifically looking at jails here. But something that I have learned that I wanted to just share with you all is that we know that jails operate in silos and a lot of times seem really disconnected from the county. And as hard as it is, breaking down those silos and collaborating with the public health departments, like we've seen happen with COVID, and then connecting with the community mental health agencies is really crucial in order to look at how to best help people with behavioral health needs. Because the data is everywhere nationally. Jails and prisons are the de facto behavioral health providers. And as such, often under-resourced and just not prepared to deal with this. So reaching out from the silos and connecting with other organizations in your county is something that is really pivotal to changing things. Next slide. Okay, this is the practical part. This is the takeaway for, in addition to breaking down silos and all those things which seem kind of bigger, this is the practical. The best thing that we have found for jails with behavioral health is to do a screening at booking. Again, recognizing that there's often staffing and resource challenges. The screen that we recommend is called the K6, and it is just a brief 6-question thing. It can be administered at booking or classification, and it is just something that can flag if a person who is booking in is at risk for a behavioral health concern. And what that means is, we know that there are standard suicide questions, but this gets at the person who might not be symptomatic as much, but at high risk. And it also addresses other concerns. Really what it is a tool for you to say, hey, jail medical, this person might need to come across your path a little bit quicker than others. So again, know your population. Second, familiar faces have become something that we are hearing a lot more counties look at, and specifically jails. And really, we recognize that every jail has their population that cycles in and out. And what we're looking at is how do we interrupt that cycle, right? Like, how do we stop that revolving door? And a really easy way to do that is to utilize the data that you have. How many times, who are the people that have booked in more than 5 times in the last year? And just coming together with a list. Who are these familiar faces? And then reaching out to your public health agency or your community provider and say, hey, these people have been in the jail a lot. Are they on your radar? Chances are no. And making that connection is huge to stopping that revolving door. And again, as a researcher, I have to say data matters with all of this. So what we've found is that the IT people in jails are honestly the most favorite employee a lot of times, because they're the ones who understand how to use this data, and data is linked to funding. So having this data is really important. And I know I've already touched on this, so I won't develop, but partnering with your health, local health department and community mental health agency really can benefit you and your population. And then finally, really practical smart releases. We were really surprised to learn at how many jails release people at 12:01 in the morning, regardless of the need of the people and being released. And we just really recommend that if someone is on your radar for a behavioral health concern, that they are released during business hours so that there's a chance to connect them with treatment and to avoid some of the pitfalls that come in those first 24 to 48 hours. So that's it. That is a really broad overview of many people's lifetime work that I've tried to cover in 10 minutes. I'm happy to answer any questions that you have later. And thanks again for having me.
Thank you so much, Nancy, for that presentation. And now we'll shift over to Dr. Carmen Mcintyre and her presentation entitled Risk Factors for People Who Are Incarcerated with Behavioral Health Needs During the Pandemic. Thank you, Stacy.
All right. Well, good afternoon. Thanks for having me. And I didn't include my notes in the version that I sent you, so you should be good for this one. So next slide, please. The COVID-19 pandemic is exposing racial disparities in health at a crucial point in U.S. history for race relations. So people of color are being infected and dying at much higher rates than other groups. And Black, Hispanic, and Native Americans are disproportionately affected compared to whites for COVID. So if you look at the graph that we have here, the bottom set of bars is for Michigan. Black or African Americans were 14% of the Michigan population, but were 33% of the cases and 41% of the fatalities. Illinois looks pretty much the same as we do, so yay, Midwest, but Louisiana, Black Americans are 32% of the population, 51% of the cases, and 70% of the deaths. So huge disparity there. Now, this is in part due to the lack of equity in the social determinants of health that contribute to COVID-19 outcomes, including things like one's physical environment and access to high quality healthcare, which from our preliminary data at the DOC, some of that seems to be evening out with respect to our outcomes. However, the other contributor to higher risk for adverse outcomes in COVID-19 are the higher rates of chronic health conditions in persons of color. Now, these are often the result of transgenerational epigenetic effects from generations of trauma from structural racism in this country. And those things aren't evened out by coming into a carceral setting. So what does all this matter when I'm supposed to be talking about incarcerated persons with behavioral health disorders? Well, next slide. So this slide will show you the MDOC racial composition. So whereas whites are about 75% of the Michigan population, they're only 43% of our prison population. And Black Americans are 14% of the state of Michigan composition, and yet they're over 52% of our population in the Department of Corrections. And this is mirrored in many of our jail settings. So if you have Black citizens who are overrepresented in carceral settings, and then this is a population that's at higher risk for severe COVID-19 outcomes, then jails and prisons really need to plan carefully about how they're going to look for COVID and its outcomes in these populations. And this is going to carry over into behavioral health. So let's go to the next slide and talk about behavioral health specifically. So we know that in carceral settings, persons with severe mental illness are overrepresented. And in prison settings across nationally, SMI or severe mental illness is about 14% compared to 10% in the community. I'll tell you that in the Department of Corrections, at any point in time, about 25% of our male population will be on our mental health caseload. And in our women's facility, it's between 50 and 60% that'll be on our mental health caseload. So our rates are a lot higher than this. PTSD, I want you to remember PTSD and schizophrenia in particular, because I'm going to come back to those. But PTSD, about 48% of persons in prison have PTSD compared to 6% in the community, and 10% for schizophrenia compared to 1% in the community. And you'll see these are also overrepresented for attention deficit disorder, bipolar disorder, and major depression. So next slide, please. Now, this is coming from the National Health Survey. And we know that grief and loss, isolation, fear, and loss of income are causing mental health disorders or exacerbating existing ones during this pandemic. Now, people said over the year between June of 19 and June of 20, and mind you, in June of 20, we were only a few months into this pandemic. And already people said that they had started, 13% said they had started or increased their substance abuse because of COVID, and 11% were seriously considering suicide. And when you look on the right side of the graph, you'll see that our anxiety and depression have gone up significantly since the start of this pandemic. Next slide, please. So we know that persons with severe mental illness are at higher risk for self-harm, including suicide behaviors. And this slide is simply showing you the increased risk for self-harm based on the mental illness. So depression clearly being high, anxiety disorders, which would include your PTSD, schizophrenia, and then substance use disorders, whether they're alcohol or other. So these increases that you saw on the previous slide in mood, anxiety, and substance use disorders is important because these are the disorders most commonly associated with our highest risk for self-harm. Now, in jail, typically suicide is the leading cause of death, and it's not other chronic illnesses because of the relatively short stay that people have in jails. Jails also have a higher percentage of the population with severe mental illness, including substance abuse, than prisons do because with diversion programs, a lot of people don't make it to prison. So I think that looking for self-harm and considering problems with persons with severe mental illness are especially important in jails, even more so than in prisons. Next slide, please. So let me share a little bit about what we now know regarding mental illness as a COVID-19 risk and vice versa. We know now that patients with severe mental illness have a higher risk for severe outcomes from COVID-19, including death. And this was first published in Lancet last year. And they found that there, specifically for ADHD, bipolar disorder, major depression, and schizophrenia, that there was higher morbidity and mortality when exposed to COVID than those without this mental illnesses. However, now we know, and this was just published in January of 2021, that schizophrenia as an independent factor is second only to age in increasing the risk factor for dying from COVID. So we know age and then things like diabetes, hypertension, high cholesterol, COPD, that those are things that increase your risk. But the highest risk is age. And now it turns out that schizophrenia is above all those other chronic conditions in increasing your risk factor for dying. Also, now more is being published about the actual brain and long-term neurologic effects from having the COVID infection. And it can include brain complications, including delirium, seizures, strokes, brain fog, dizziness, and headaches. This can be seen for extended periods of time after the COVID infection, or what we're calling long haulers. And these are the very conditions that actually increase risk for developing dementia later on in life. Also, because of the lockdowns and in jails and in prisons specifically, folks don't have a lot of freedom of movement, freedom of association, and those kind of things when they're in jail or prison. And because of the movement restrictions that we have and the quarantines and isolations, this is leading to an increase in depression, anxiety, and other disorders. And our next speaker is going to talk more about isolation. Next slide, please. So I can't speak about jail and prison settings without speaking about trauma. And we know that trauma exposure, including chronic victimization as well as early childhood exposure to trauma, increases the likelihood of perpetration with crime and involvement with law enforcement. In carceral settings, we have much higher histories than the general population of sexual and physical victimization, which then is correlated with our much higher rates of severe mental illness and particularly PTSD. And unfortunately, in jail and prison settings, trauma continues, particularly physical and emotional victimization. So people are re-traumatized by being exposed to situations that bring back to mind their own trauma, but also, unfortunately, we have new and ongoing incidents of victimization while they're incarcerated. So chronic or early childhood trauma is associated with chronic inflammatory conditions, which then lead to chronic health conditions. And these include things like diabetes and obesity and COPD and hypertension, all those things that we know are risks for COVID. But also a problem with the chronic inflammation is that your body's reserve give out. And when you're exposed to infections, when you're exposed to challenges to your body isn't able to respond to them in the same way. So folks with this kind of PTSD and this trauma background won't be able to mount as adequate an immune response when they're challenged with COVID, and therefore tend to have poorer outcomes. Now, folks that become positive with COVID, they're isolated. So there's even more of that isolation and restricted movement. But we do know that people, even pre-COVID, who end up in the ICU have high rates of PTSD development from being in the ICU. So we're finding that folks with COVID that end up in the ICU are developing PTSD or have exacerbation of their PTSD. And we're concerned that the same will be true for those COVID-19 survivors, even those who were never hospitalized, because of the prolonged isolation that they have to go through. So what does all of this mean? It means we have to account for behavioral health as well as race, age, and chronic health conditions when we're coming up with our risk mitigation strategies for COVID. One thing to be aware of is we often have persons with severe mental illness cohorted in the same place in our jails and prisons. For example, mental health units or inpatient units. And it's the same thing for our elderly or medically frail population. So what does that mean? These are our highest risk folks to have the worst outcomes from COVID, and yet we put them all together. So when COVID hits that unit, it's going to go through like wildfire, and it's going to hit them particularly hard. So we might have to rethink how we house folks with severe mental illness as we're dealing with COVID. New guidance was released last Friday, but all of us should have been already considering regular surveillance testing in our carceral settings in general because of the close housing, but in particular for our highest risk units, which would include those with severe mental illness, as well as those that are elderly and medically frail. You want to identify when COVID hits those units and treat as quickly as possible. When you have positives and close contacts, evaluate vital signs, especially oxygen saturations and heart rate. Temperatures are next to useless. So we want to monitor the O2 sats and the heart rates daily, several times a day, particularly for those who are symptomatic. But please remember what I said, that those with severe mental illness are frequently have the trauma rates or the high trauma exposure. They're going to have chronic inflammation. And so therefore their immune system might not respond in the way that a person who doesn't have chronic inflammation has. Our early warning symptoms, including temperature and heart rate elevations, are as a response to our body's initial immune reaction to the COVID exposure. If our bodies have pooped out and we can't launch that kind of a response, then we will be asymptomatic until suddenly the person crumps and has a very bad outcome. So even for your asymptomatic people, particularly those with mental illness, as well as the medically frail and elderly, continue to monitor those vital signs at least once a day. And then consider, before releasing them back to the general population, they tend to have development of lung and cardiovascular symptoms later. So consider doing a chest x-ray before you release your SMI people who are asymptomatic back into the general population. And that's what I have for this section. Looking forward to any questions that you have later.
Thank you so much, Dr. McIntyre. Before we jump into the presentation by Dr. Zielinski, I wanted to remind everyone again that the Q&A chat box feature is available and open. So if you do have questions, please feel free to add them in there. And then we will get to those during the panel discussion. And you can also ask questions during the panel discussion as well. With all further ado, please welcome Dr. Melissa Zielinski. Thank you.
All right, thank you very much. I'm gonna see, I can control the screen, but I don't see controls. Oh, there we go. Okay. So hi everyone, I'm Dr. Melissa Zielinski. I am an assistant professor and research scientist at the University of Arkansas in Medical Sciences, which is down in Little Rock, Arkansas. But I am first and foremost a clinical psychologist by training. And that's kind of the lens that I'm going to bring to this section of the presentation today. I think I have a somewhat unique experience of not working for prison or jail, but running therapy groups, actually particularly focused on trauma recovery, as an external volunteer within these kinds of facilities for about the past 8 years. And so I'm going to just kind of jump right in. I'll focus heavily on how incarceration relates to social isolation, the confounding effects of COVID-19, and kind of the recommendations that we know from research done prior to the pandemic for how to potentially mitigate harms that we can anticipate, given that isolation is part of the strategies being used in response to COVID-19. So I think it's just important to start with recognizing that at a foundational level, our incarceration is about isolation, right? We take people from their communities and place them into confinement. And the degree of isolation that people experience in non-COVID times, of course, is going to vary based on both the structure of a given jail or prison, right? Like the practical, physical limitations and setup of those spaces, as well as based on considerations related to the individual person and kind of their process through the system. So for example, how long they've been in the facility, security considerations, programming or medical needs, right? So this can vary, and in isolation exposure would be, maybe the least in congregate living arrangements like dormitory housing to extreme when people are housed in something like solitary confinement. And of course, the degree of exposure to isolation may change over time as people's statuses changes. And of most relevance to this talk, their status may change due to the COVID precautions. As we all know by this point, right, social distancing is a primary recommendation by CDC to limit virus spread. Varying kinds of isolation are used in response to infections, in response to trying to manage people that are especially vulnerable and such. And so that, of course, is going to compound. The thing is that, of course, these measures are not without risk. So there's been decades of research demonstrating the harms of extreme isolation during incarceration. For example, the solitary confinement research, and even linking that kind of extreme isolation with post-release mortality. Conversely, there's research showing that maintaining social connection and activity during incarceration helps people post-release. And in non-COVID times, we have, specific processes in place to combat isolation. So for example, visitation, different methods for distance communication, programs which help people kind of get together with other people in classroom or group settings, and then rec time. But then, enter COVID, and it's threatened essentially nearly all or all of these mitigating factors that we have in place to try to combat isolation exposure. So for example, visitations were shut down in nearly every state very early in the pandemic. Programs were suspended, rec time was suspended, movement was limited. And we are now at the point, being a year into this, where we do have some research. I can't speak to jails specifically, but 100% of state prison systems, for example, suspended in-person visits very early between March 7th and March 19th of last year. And many of these suspensions are still in place. You can kind of see quickly how it stacks up across states here, with most of it happening within the first 2 weeks of March. And then, as I mentioned before, there are, of course, these other isolation measures in effect. And so these make sense in terms of infection control, right? And I'm a pragmatic person. You can't help the psychological health of a person if they're dead. So that needs prioritized. And at the same time, I think there's an argument to be made based on what we know that that isolation during incarceration has been shown to be a matter of life or death. And so at that second stage, it needs the same careful contemplation and commitment to mitigation of harm as is the case for infection control. So with that as the backdrop, what I want to encourage us to think a little bit about, especially for jail administrators and public health officials, is to give isolation that same attention because of its importance in determining people's health and behaviors. And the first thing is, just at a very foundational level, is just to anticipate that there will be negative effects of lockdown, and that we can say that pretty definitively. We know this from the research we've had well before COVID, and I'm sure, being a year into the pandemic, many people on the call have seen this play out in facilities by this point. Especially in the case of something as extreme as a complete lockdown or medical kind of confinement with limited privileges, we would expect that almost all people that are subjected to prolonged isolation would have negative effects, even people that don't have pre-existing mental health diagnoses, and that these effects may persist even after isolation ends. You can see common reactions. We would expect to range from things like physiological reactions, low appetite, trouble with sleep, sweating, to cognitive changes like confusion or impaired concentration, irritability, mood kind of changes, and even potentially hallucinations and paranoid ideas. I'd encourage y'all to pay attention to specialty populations within this. So it's not, these populations are more at risk for negative effects, including people with existing mental illnesses, as Dr. McIntyre talked about, pregnant and postpartum women and older adults. And so now I want to close by just thinking about strategies. So I'm going to assume that by this point in my presentation that you've at least partially bought in or fully bought in to that mitigating isolation as a secondary effect of the pandemic is something you want to take seriously and something you want to address. So my recommendations here are going to kind of be a combination of acceptance-based strategies and change strategies, something that is me bringing kind of my therapist lens to the table here. So to me, acceptance does not mean just get over it or just like it is what it is. It means really acknowledging the reality that this is a huge problem and it sucks, and that we're better off finding a way forward once we acknowledge that, right? So really taking that in and using it. And then for jail leadership, change strategies, using the power and authority that you do have to make the changes that are necessary to ensure that pandemic control measures intended to avoid death and severe suffering from COVID aren't unintentionally, inadvertently leading to death and severe suffering due to isolation, right? And so, as I said, this will be geared both towards staff and people that are incarcerated. And so I'll say quickly as a backdrop, we've developed some tools that are available via Wayne State's website now, or by contacting me directly, one kind of for each. And I'm just going to kind of hit some highlights since we all have short times together today. So for staff recommendations, jail administrators, I think the the biggest thing that you can do is really devote energies to just finding ways to facilitate meaningful social interaction and deciding that you're going to do that and make a commitment to do that. Making sure that there are extra checks on people that are especially vulnerable, but for example, opening up our distance communication methods via expanded access to technology. Again, we don't have data, nationally from jails, but pulling off of the Department of Corrections literature, we can see that 48 out of 50 states added free phone calls, for example, during the pandemic. And there are a number of other types of measures that have been put into place, like free video calls for places that have that capacity, or emails for places that have that capacity. Also know that stakeholders are kind of coming to the table to create that capacity if it doesn't exist. If you have people on true lockdowns and on very heavy restrictions, really take seriously counteracting sensory deprivation. Try to create lighting that's consistent with human sleep-wake cycles. Really think about how you can expand access to amenities like radio and television, and to enrichment activities, personal items, snacks, things that provide sensory variation and kind of break up the time. Prioritizing relief from confinement, making sure that folks have daily time outside the cell, access to outdoor exercise, importantly, updating and orienting information to kind of help people distinguish between days, and control over their environments, however small. And I would just encourage places to also remember your partners. If you're used to working with volunteers, the volunteers kind of got shut down as visitation programs got shut down because of being, non-essential to kind of the core facility operations. But that doesn't mean you don't have partners that aren't willing to find you things that you could integrate and kind of repurpose their time to help. And then just briefly switching over to coping strategies for people that are incarcerated. So this sheet, the longer version, like I said, is available. We pulled this from interviews and research done with people who had experienced long periods of solitary confinement and kind of their suggestions for how they got through it. And also studies from people who had experienced solitary confinement in other settings like prisoners of war. What you're going to see as I scroll across slides, and I'm just going to do that quickly, is most of the strategies focus on a couple of things. So distraction and keeping busy, right? Finding things to do, as you see a lot of examples of here. Remembering to do things to take care of the body. Doing exercise that can be done in modified ways in a cell, for example, paying attention to staying hydrated, things like that. And then, what came across in that literature really strongly is using one's mind, because you're stuck, right? Like you're at the mercy of whatever the system kind of is separated. And so people have talked a lot about using the mind and the imagination. And so none of these are change focused strategies, right? People can't do that for themselves in this setting, but you can encourage people to just improve the moment is the name of a skill we use in one form of therapy. It's just taking the edge off a little bit, kind of through mental strategies. So that brings me to the end of my section, and happy to take questions.
Thank you so much, Dr. Zielinski. And that brings us to our panel discussion. And I will actually propose the first question to you, Dr. Zielinski. What do you think in regards to your presentation and the content you just shared around social isolation and strategies to mitigate and combat that? What do you think about having groups, when groups are allowed, to encourage inmates to discuss and reflect on their COVID-19 experiences?
I think that's an excellent idea. I think, it's again, that balance of taking into account that, like, when is that going to be safe in context of what's going on in that particular facility, and groups do come with a little bit of an increased risk. But if you've got the space to spread people out, anything to increase meaningful social interaction and encourage people to process their experiences, right? And define, I highlighted that word control kind of about environment in one of the slides, really being open to hearing from people themselves about what they need to recover. And I think groups can kind of help facilitate that process.
Thank you. Thank you for sharing. For you, Nancy, if people are diverted from jails and prisons, are they still at an increased risk for COVID-19 if they go to other group living settings?
That's a great question. I don't know that is actually a question that I should answer. I think that might be more of a medical one, Tyler, if that's okay.
No problem. We
I'll
can
go to
shift that.
Dr. McIntyre on that one.
No problem. I was just going her direction. Dr. McIntyre, would you like to pick that question up? If people are diverted from jails and prisons, are they still at an increased risk for COVID-19 if they go to other group living settings?
So, I mean, so if you're diverted, are you still at risk? I mean, some people might be more at risk in their usual community setting than they are anywhere else, just, just because of the kind of setting. So the more that you have people, the more people you have in one place, and the more that place has folks coming in and out, the greater the risk is going to be for anyone. So, jails and prisons are frequently by the CDC considered on par with congregate settings such as nursing homes. For some units, that's the case, but it's not the case for all units. Some units, the risk would be on par with a closed community setting, such as what used to be called halfway houses. So programs that are specific for returning citizens with substance use disorders or with criminal sexual conduct or, with severe mental illness. So the problem with those settings is people live close together and folks from out in the community are routinely coming in and out and every day. We don't lock down the staff that work there. They don't have to live there and be on lockdown along with the residents. And that's where that risk comes from. So yes, someone who's diverted could still be at risk if they go to a congregate setting. The type of setting will determine the risk.
Thank you for sharing that. Nancy, you highlighted the need for collaboration between personnel working within jails as well as those who work outside of it in the community. Can you share some strategies that may increase that collaboration? We're assuming, of course, at this point in the pandemic, a lot of communities are connecting and networking with one another, whether they're working inside the jails again or working outside. But what tangible and practical strategies do you have to either foster stronger relationships or also identify existing and non-existing resources that are needed for communities?
Sure. So looking at it through the COVID lens, what I would think about is how in one of the counties that we work, the health department recognized that the jail didn't have the capacity to do the testing and the mitigation and was able to provide funding to bring people in to do some of that COVID testing. And in addition, they were also able to add on testing around substance use disorder. So that's a really simple example of a county public health and a county jail partnership with that, COVID specific. What I've seen in other communities around Michigan that really works is honestly just jails asking for help from their community mental health agency, saying, hey, this is our list of people that come in every day. Will you just look through it and see if any of these are your people? Because chances are, if you can't find them and they've disconnected services, we've got them. So it's just a really easy way of starting to break down some of those barriers. And what we've also noticed is that for a lot of this to work, there needs to be a champion, and the jail is a really great place to start that process, and just is coming to the forefront of the county and saying, hey, we've got these issues. We need partners. What can you do to help? It's kind of just that simple.
Yeah, thank you for sharing that, Nancy. Dr. McIntyre, there was a comment in the question and answer box that kind of asked a little bit about what the MDOC is doing in communities, specifically here in Michigan, of course. The MDOC, for those unfamiliar, is the Michigan Department of Corrections. With that being said, and understanding that patients with SMI have higher risk for severe clinical outcomes of COVID-19, based off of your presentation, can you share some examples of resources or interventions that the communities you work with are using to address this multifaceted need?
Sure. And it relates to another question that I saw in the chat about, providers kind of during the lockdown, providers not being able to come in. So when you have, as I said, when you have COVID come in and it kind of is going through a unit, that unit will be isolated. And initially, being very cognizant of the sensitivity of the content that comes up during behavioral health sessions. You know, you're talking about trauma, you're asking people about hallucinations and delusions, about thoughts of suicide. You don't really want to do those in a setting where everyone can hear, right? And so we, you know, so initially, while we could certainly have our providers go in full PPE to the units to see people in, you know, in their cells, that works a lot better if you're a medical provider, you know, and you can kind of be one-on-one there, but nobody hears the outcome of you listening to someone's heart or you're checking someone's belly. Whereas when you're talking to someone about, you know, their psychological thoughts, that can be overheard. So at first, those were kind of cursory. And if we couldn't pull people out to the units, at least we had folks checking on them, but it wasn't in-depth therapy. So after that, what we started doing is having iPads that we could take to the unit with a hotspot. Because as you can imagine, in the DOC, there's not internet available all the way through the facility. So to minimize people coming from units that might have been infected all the way to wherever healthcare was, we have designated rooms where there's privacy on each of the units, and we can take the iPads or the whole mobile unit with the TV and, you know, the whole Polycom kind of thing to the units and have reinstituted face-to-face. And I know it's not the person there, but, you know, it's face-to-face where they can actually see their provider and have their meetings. We've also become much more aware, not just of the routine, you know, let's say somebody had bipolar disorder and they were stabilized, and so you're only doing med reviews once every 3 months or so. We're aware that we have to check in with people a lot more often to see how they're psychologically coping. So trying to increase the frequency of those visits. Maybe not as long as sessions with the qualified mental health professionals, but more frequent, you know, kind of brief check-ins, just seeing how folks are doing.
Thank you. Thank you for sharing that. Dr. Zielinski, we'll ask you this next question that was put in the chat, and I just have to go back and find it. I'm sorry. So there was a question asked around motivational interviewing and other models in the behavioral health space. Specifically, this participant asked, what are your thoughts regarding the evidence-based practice outcome models used in the behavioral health arenas today, such as motivational interviewing? Is this model being used to assist in the transformation of the criminal justice system and the staff's frame of reference, specifically as it relates to prisons and jail populations?
You know, that's a really great question. It's hard to speak broadly to because I am not aware of any large scale study that has like systematically examined mental health practices in prisons or jails. So we have one from the 2006-2007 came out that looked at substance use treatment practices specifically that was done on a national scale, but I'm not aware of anything that's been done that could sort of speak to how wide of a reach that evidence-based programs have had. I can say that's for sure needed. I can also, you know, give a plug to that. I think, you know, I would never, of course, recommend that anybody become incarcerated to get access to mental health treatment. I think it's a huge problem that this is where people are having to access mental health treatment. But that being said, given that we incarcerate so many people that have mental and behavioral health needs, I think we sure ought to offer evidence-based practices there, and motivational interviewing would be one of them. We also have many you know, medication options. We have many psychotherapy options that have been shown to be effective and work for depression, PTSD. They need adaptation in a lot of cases to work in prisons and jails. And I don't mean like the mechanisms of the intervention, like how it works. I mean more like this thing takes 3 months and people aren't there for 3 months. So how do we kind of keep the core things that work and do it over a short time frame, things like that. You know, there's a real need for that. Yeah, I would plug that, but also say I apologize. I can't answer that question directly. I'm not aware that anything's been done to speak broadly.
Yeah, no problem. Is there anyone else on the panel who would like to address any of that question that was just asked?
I can address it from the Michigan Department of Corrections. So we definitely have as our standard intervention for our qualified mental health professionals is the cognitive behavior therapy. And folks have received training. We've also had folks certified in motivational interviewing. It's on our strategic plan that the whole system, not just healthcare, but the corrections officers and staff, all be trauma informed. So we've got that training going on. We have a CIT pilot going on at the Macomb site. We have introduced medications for addictions treatment and have received a grant so that we could bring on, and I don't remember, it's something like 15 or 20 additional substance use therapists. And have gotten all of our providers C-waivered or X-waivered rather to be able to prescribe buprenorphine. So yes, we definitely want to align ourselves with the community standards and the implementation of evidence-based treatment.
Thank you so much. Nancy, this next question was also put in the chat. During COVID, jails have also locked down outside providers from coming into the jail. What kind of adaptations may be made to manage the mental health needs of those within the jails? And I'm wondering if you can speak to some of the communities that you're working with and what adaptations they may have made, as well as what strategies they may be using. Thank you.
Sure. And this actually piggybacks off of what Dr. McIntyre was saying. So, at MDOC, there is one system and it regulates everything. One of the unique things about jails is each jail is their own system. So what one jail does could be diametrically opposed to another. So practices, and it has a lot to do with who the provider is. Is the provider a community mental health agency that's embedded in, or is it a third-party provider that is paid for service and offers a completely different menu of options? Sorry, that's a personal passion point of mine. Didn't mean to go left there. But basically, what we've really seen is jails adapt to what the numbers are in the community. So in some of our more rural areas that have actually been vaccinated more quickly because of the low numbers, they've let certain visitations start again. In other communities where there's widespread COVID still, it's not happening. I have seen a lot of telehealth options go on for even family visitations, attorney visitations. I don't know that there's any data yet on how mental behavioral health visitations have really been adapted widespread. Again, because each jail is its own system, it's really hard to capture that across. I do think that from talking to the jail personnel I work with, there's a lot of interest in returning to that normalcy because they see it as well. And a need for that. I wish there were a magic button to make that happen more quickly.
Yeah.
Tyra, can I throw one more thing in there that I was thinking
Please.
About your question for groups that Dr. Zielinski answered?
Yeah,
Something
please.
that I want to call attention to jail staff is there's a real need, in my opinion, for jail staff to have the kind of resources to deal with this COVID trauma as well, because we know that when the staff is struggling with trauma of their own, that affects the population of the jail.
Yes.
So a cohesive approach to not only looking at trauma from COVID in the population, but also in the staff, many of whom have lost, significant portions of their staff to this. Just something I want to put a plug out there for. I think it's something that really would benefit everyone to address as well.
Yeah, thank you, Nancy. That definitely helps and addresses the overall ecosystem within the criminal legal system. Dr. Warso, if you're still on, I know there was a question that you had as well, and I think it would be great to end with that question for today's panel discussion before we wrap up.
Yeah, I guess, before we wwent live on this, I had just mentioned the new guidelines that came out from the CDC last week. I guess you know, there are some changes that the CDC is recommending in different mechanisms, and I didn't know if any of the, if you had read them. I did, and I think prior I thought maybe, you know, some people had that. What do you think this is going to improve the overall mental health and behavioral health of the jails or in the prisons? Do you think it's going to make it harder? I have some thoughts about it, but I'm interested in what you think.
And that's a question to the panel.
I'll jump in. I think the increased surveillance testing, you know, here in Michigan, there are public health orders that are already mandating the weekly surveillance testing. If you have a single positive for a staff member or a prisoner, we're required then to do weekly surveillance testing of 100% of prisoners and staff for until you've gotten 14 days without a positive. So with community spread being what it is, and over a year into this, and people have fatigue about all their precautions, you know, we had huge surges, March, April, May. Things got a little bit better. Then August, they started going up, and big surges again through late fall. And things got better over the holidays, and now we're getting these big surges, and we've got the variant. So, you know, when you're saying about, is it going to help any, are things with kind of the mental health and the stress to the staff and to the incarcerated persons going to get any better with this? No. No, I mean, you know, if it's your job and you know you have to be tested every day when you're walking into your job, that's one thing because you're getting something out of it. I think for a lot of people, this constant testing, while I think it's good for health reasons, it keeps on letting you know that we've got this thing that's still going on, and you're not getting a sense of relief that things are getting better. So, you know, it's one of the things that you have to keep aware of, the kind of education that you're providing to folks, and you know, the motivational interviewing that you're using to help convince people to get their vaccinations and whatnot. But we have a wellness committee, one for staff and one for prisoners. And so that's the kind of thing I think that gets addressed in those sorts of committees.
Thank you so much. Was there anyone else on the panel that wanted to share? Awesome. Thank you so much, team. Next slide, please, Stacy. And now I will allow my coworker Bianca to wrap us up. Thank you.
Thanks, Tyler. So please let us know if you have any additional questions. We're more than happy to respond to those questions and share more information. I do know that we have some questions that we weren't able to get to, so we will also work to respond to those as well. I want to thank you all for joining the webinar today and spending some time with us, again, to talk more about behavioral health and COVID-19 in jail settings. This does help us to further in developing COVID-19 strategies in jail settings to not only help in updating our toolkit, but also to continue informing others. I want to give a special thank you to all of our panelists for sharing their expertise and valuable information. Our next Community of Practice webinar will be April 22nd. This is on a Thursday from 1 p.m. Eastern Standard Time to 2 p.m. Also, please visit behaviorhealthjustice.wayne.edu/coronavirus to register for the next webinar if you haven't already done so. So thank you. I appreciate your time.
Thank you, everyone.